Hey everyone, it's Dr. Marcon. This is Laboratory 2526 on respiratory physiology. In this lab, we will perform an experiment studying the relationship between respiratory movement and airflow. Specifically, we can see changes in temperature with airflow during respiratory movement. We will also look at how to administer, measure, and interpret respiratory tests. So clinically, we give what's called pulmonary function tests. These tests are performed to evaluate lung function in patients. We use an instrument called a spirometer to obtain lung volumes and then ask a patient to blow in it for a certain amount of time. And based on the amount of air that the patient will blow into the spirometer, then we can kind of get an idea of how well the patient's lungs are functioning. So this is experiments in FOX 8.1 and 8.2, and then we will look at how to do calculations for the respiratory tracings. So the spirometer was made for exhalation only, and only to measure expiratory volumes. We can actually obtain volumes of inhalation indirectly by calculating them. And we have different types of spirometers. There's a dry spirometer where a patient will blow into it or a volunteer will blow into it and we can read the volume on the dial. Or there's a wet spirometer. Now a wet spirometer, it's a closed-off system. The volunteer will blow into the apparatus and it involves columns of water as well as a instrument that records the volumes of air. So we know that vital capacity can be obtained by asking the volunteer to have a max. First they have to inhale as much as they can and then they blow everything out into a spirometer. Now normally we do have spirometers that are electronic, and all they have to do is blow into the spirometer after a max inhalation until they hear a beeping sound. And the electronic spirometer can calculate the volumes electronically as well as certain percentages. But because we're a community college, we do have dry spirometers, and all we have to do is read the dial for the volumes of air that are exhaled by the volunteer. Now with a wet spirometer, we have a volunteer do it about 2 to 3 times and we read those volumes and then we take the average. We will then multiply by what is known as a BTPS correction factor, which is about 1.1. Now, BTPS stands for body temperature and pressure saturated. This is a correction factor for atmospheric pressure and whether or not the air is saturated, and helps denote a volume of gas saturated with water vapor at 37 degrees and at ambient barometric pressure. So we then, after correcting with the BTPS factor, we will multiply by 1,000. We can determine the percent predicted. We will see first the comparison of these percentages on a table 8.1 on page 303 in your manual. And we obtain the percent predicted by taking the actual volume that you were, or the actual number that we were able to obtain from the wet spirometer, and then divided by the predicted value, and those predicted values again being in that table, and then multiplying by 100%. So that is how we would get a percent predicted. So basically it's what you actually blew divided by the predicted value. So this is the setup for the Biopac part of the lab. We have a chest strap that is placed around the volunteer's chest. It's made of rubber that will move with chest movement. And then we place with the nose what's called a thermistor. A thermistor is a probe that will measure temperature. Now, when a volunteer will inhale air, usually this air is cool or about the same temperature as room temperature. With inhalation, you're inhaling cool air and the temperature that will be recorded goes down. And then if you are exhaling, basically the air has had a chance to warm up in your lungs and the temperature goes up, meaning the air is a lot warmer. So we can see that it is recorded with the Biopac with the temperature denoting airflow being on the top, and then the chest movement indicating inspiration and expiration on the bottom of the recording. So once we calibrate the Biopac, we measure chest movements and airflow temperature, and we will do it under 3 different conditions. So the chest strap will measure rate as well as the depth of breathing, and the thermistor will measure airflow temperature. So again, when we inhale, we pull cool air or room air temperature into the nose, and then when we exhale, we blow warm air out of the nose. So these are the 3 conditions that we are going to take a look at. The first one being eupnea. Now, eupnea means normal breathing or breathing at rest. So eu means normal, pnea means breathing, so normal breathing. And we will measure normal breathing or breathing at rest for about 20 seconds. After that, we will ask the volunteer to hyperventilate using rapid, deep breaths. Now, according to the slide, it's recommended for 30 seconds, making sure the volunteer doesn't pass out. But we can do this part of the lab for less than 30 seconds. And it's been recommended that perhaps anywhere between 10 to 20 seconds will be okay. And then they are given a period to recover, at which point they will then undergo hypoventilation, which are slow, shallow breaths, and then have a period of recovery. So the first table that you are going to record is respiratory readings during eupnea. So you'll have, a volunteer resting, breathing at a normal pace, and we'll record inspiration, expiration, and a full respiratory cycle. So a full respiratory cycle being 1 inspiration, 1 expiration. So during inspiration, the volunteer is breathing in, they're breathing in room air. The temperature will decrease because they are breathing in cool air. And then during expiration, they will breathe out warm air that has been warmed by the lungs, and the temperature will go up. So again, this top part denoting temperature, and then the bottom part indicating chest movement. So we can see within this picture here, inspiration. So chest movement goes it increases because we're increasing the amount of air going into our lungs. So we see as the air goes into our lungs, or as we're breathing in, this peak goes up. Meanwhile, for temperature, we can see that this goes down because the temperature is going down because we're breathing in cool air. Okay? And with expiration, as we hit the peak, max inhalation, we then expire or exhale that air, and we can see this going down. So this is exhalation right here, this part right here, going from max inhalation to expiration here. And then as we look at the top part of this recording, we can see that the temperature of the airflow is going up because we are breathing out warm air. So we can see that at this point, at this peak, we'll have max temperature reading as well as where we reach max exhalation. Okay, so 1 inhalation plus exhalation, that is 1 full respiratory cycle. So we want to take the peak of 1 respiratory cycle to the next and measure time. At that point, the computer or the Biopac will then give you a respiratory rate. So we want to look at inspiration duration as well as expiration duration. Adding those two up, we'll get the total respiratory cycle. And then with that, the Biopac will then calculate the breathing rate or the respiratory rate. Okay, and here is one complete respiratory cycle. We have inhalation with this peak going up, and then exhalation with this peak going down for the chest movement recording. So again, we want to get peak of one respiratory cycle to the peak of another. Again, we have the respiratory duration going here, and then we can calculate we record the expiratory duration going here, and we add both to get the total duration. Okay, and then at that point, the Biopac can then calculate the breathing rate. So the next table will actually compare ventilation rates of 3 different conditions. We already know how to get eupnea, but then we are going to include periods of hyperventilation and hypoventilation. So we have our volunteer undergo the 3 conditions, and we can see them actually in these colored recordings. So here we see the volunteer just under normal restful eupnea, normal restful breathing, and then we ask them to hyperventilate. So rapid, shallow breaths here. We then have a period of recovery and then ask them to do hypoventilation. Okay? And then again, we have our period of recovery. So this is basically what the tracing would look like on the Biopac. This is what we would expect to see with, again, airflow and change of temperature on the top part, and then the chest movement on the bottom part. And we can kind of highlight an area and then zoom into it so that we can see the individual waves. Again, we know that with hyperventilation, the change in temperature, the delta T, will be lower because the temperature will be lower compared to the temperature when doing hypoventilation. So with the breathing rate, in Table 2, we want to get the breathing rate as well as the ventilation depth for all 3 conditions. With the breathing rate, you get the total duration of a respiratory cycle, and the Biopac will calculate the breathing rates. We want to use the BPM function after highlighting one respiratory cycle. Now for the depth of ventilation, this is how much it goes up and down, and this is measured in millivolts. We measure as the peak-to-peak difference from the chest depth recording on the bottom. So if we look here from this peak to the next peak, so this would be the depth of breathing. Okay, this would be for inspiration, this would be for expiration. So that was how we would get ventilation depth. And then we would do that for all 3 conditions, for eupnea, hyperventilation, as well as hypoventilation. So then we want to measure on a representative respiratory cycle each condition for the peak delta change. So delta, of course, is the Greek symbol for change. So we see delta or temperature or change in temperature. So we want to look at we want to measure the delta T between max inspiration and the peak delta temperature, or delta T or delta temperature during eupnea, hyperventilation, and hypoventilation. So again, we want to highlight one ventilation cycle to determine peak delta temperature, so P to P, and then the time between max inspiration and peak temperature, delta T. So how do we do that? If we highlight one respiratory cycle and then make it a little bit bigger, then we can figure out these values. So the peak delta temperature, this is the point where there is the greatest change in temperature. and it's measured as the peak-to-peak change in temperature. So we know that the top part is airflow and the bottom part is chest movement. Okay, we can see again when the bottom part or the bottom recording goes up, this volunteer is going through inspiration, and when this part goes down, this is expiration or exhalation. So we want to see the point where there is the greatest change in temperature. So we want to measure from the time between max inspiration. So this right here, this peak right here is max inspiration, and we can see that at this point the temperature has decreased, and will decrease because we're inhaling in room or ambient temperature, which is lower than the air that we will breathe out. So as we take a look at the temperature at max inspiration, we then want to take a look at the point where we have max exhalation, or I'm sorry, max expiration, where we can see the next peak here where there is a increase in temperature. So we want to measure the time between these two. So from the max inspiration here that we can see at the bottom to peak temperature, or delta T here, which is the same as max expiration. Okay, and then we measure this time, this shaded area here. So we want to measure the time it takes from max inspiration of the chest movement on the bottom to the point where the temperature reaches the maximum height. And again, the temp reaching max height is about the same time as max expiration. The point where there is max inspiration is again where the temperature is the coolest, whereas the point of max expiration is where the temperature is the warmest. Okay. And then we also want to measure respiratory depth. This is the peak at the bottom and how long it takes to get to max expiration. So here, this time right here, okay? So this is how we're going to associate respiratory depth and temperature, specifically change in. So I'm going to go over the discussion for this first part of the lab of respiratory physiology. There will be another discussion for this lab focusing on the respiratory tracings and how we obtain that, but that's a little bit more complicated. This first part of the lab, not so complicated. Basically, we are using the spirometry to help us kind of get an idea of vital capacity of the lungs. Vital capacity is defined as the maximal volume of gas that can be exhaled after a maximum inhalation. Now, usually in a clinical setting, we use a measure of time. Like, say we want to measure vital capacity after a minute of the patient blowing into the spirometer. However, because we don't have an electronic spirometer and we're only using a plain non-electronic spirometer, we are not using unit time. Rather, we're just finding out what the vital capacity is after the patient has finished, or the volunteer has finished blowing into the spirometer. So we want to measure the vital capacity of the spirometer by only exhaling into it. There is a table in your lab manuals that gives predicted vital capacity. And the table that I'm actually putting in this PowerPoint is coming from the internet, but on page 295 in that white manual that you have, it actually has a table on predicted vital capacities in females, and there should be a separate table for males as well on the next page. So what we would do is we would use the age and height in centimeters in the table to predict vital capacity. Now, in order to convert height, usually we measure height in feet and inches. We basically want to get the person's height and convert it to centimeters. We would multiply the person's height in inches by the conversion factor of 2.54 centimeters per inch. Once we obtain the height in centimeters, we then want to use or determine the percent predicted using the following equation, which is percent predicted equals the measured vital capacity divided by the predicted vital capacity, and then of course multiply by 100 to get the percentage. So an example of this we can see on the next slide. If we want to predict the vital capacity for a 21-year-old female who is 5'3", so 5'3" inches tall. So first, we want to look for the volunteer's age. Now, this is kind of problematic because it doesn't have a row for 21, but we can just see that we can go between 20 and 22. And then we want to get her height in centimeters. So there are 12 inches in a foot, so 12 times 5 is 60, plus 3, that's 63 inches. We then want to multiply that number by 2.54, that conversion factor, and we will get roughly about 160 centimeters. Okay, so then we would grab her age is 21, so we would go between 20 and 22 to kind of interpolate the number for her height. So we can see that her number would be between 3,170 and 3,135. So we kind of just want to have an idea of the number that's exactly between those, in the middle of those two numbers. So the difference between these two numbers is 35. Divide that by 2, that's about 17. So then we add 17 to 3,135, and we get 3,152 milliliters. Okay? So we can write that. Her predicted should be 3,000. Oh, let's erase that. Her predicted should be 3,152. I need a stylus. So 3,152 milliliters is her predicted based on this table. So we want to determine the percent predicted by following the equation using the percent predicted vital capacity for our subject. Let's say that we measured her vital capacity at 2,950 milliliters. So again, using this formula, percent predicted equals the measured vital capacity divided by the predicted vital capacity, and multiply that by 100. So plugging the numbers that we have, her measured was 2,950 milliliters. The predicted that we got from the table was 3,152 milliliters. So divide those two numbers, multiply by 100, and we get the percent predicted of 93.6%. Now, normal vital capacity is generally considered to be any value over 70% of the predicted value. So this subject is within normal limits. Okay, so this is how we calculate our percent predicted vital capacity. So this first part of the discussion is going to discuss lesson 8 of this lab. This lab is when we had a volunteer, we put a chest strap around the volunteer's chest, and it was made out of some sort of flexible material that kind of moves with the volunteer's chest expansion and compression. We also placed a thermistor. So a thermistor is this kind of probe that we taped onto the face of the volunteer, and the little probe isn't actually sticking into his nose, it's just right in front of that nostril. So we tape the thermistor and make sure that the tip of that thermistor is just outside of that nostril. So when we have our volunteer all set up and hooked into the Biopac, we will see this recording. So again, the top part of the recording is temperature of the airflow, and the bottom of the recording is the chest movement. And we can see the change in temperature with the valleys and the peaks. So valley being a lower temperature compared to this peak here, which is a higher temperature. And then with chest movement, it follows the expansion and compression of the chest. So if we are expanding the chest, meaning having an increase air going into the chest will expand, and we can see this peak representing expansion. Whereas when we're exhaling, we are decreasing the volume within our chest, so chest movement will go down. Okay, so with for chest movement inspiration, we see the peak here at the bottom recording representing the chest expansion, whereas expiration will represent this valley here showing chest compression. An air temperature inspiration is a valley because the volunteer is breathing in room temperature, which will be lower compared to the air that is being expired, which has had a chance to warm within the chest. So the temperature being breathed out by the volunteer will be higher and represented by this peak. Basically, what we're doing with this first part of the experiment is applying Boyle's law. So Boyle's law is basically saying pressure, P, is inversely proportional to volume, meaning if the pressure goes up, the volume goes down. Or if the volume goes up, the pressure goes down. When we inhale, in order to ventilate, we have to have a change in pressure to create that pressure gradient or differences in temperature between the atmosphere outside of the lungs and the actual pressure within the lungs. So we know that fluids and gases move because of a pressure difference. To move air into the lungs, you have to have a change in the pressure in the lungs to create the pressure difference. To move air into the lungs, you want to decrease the pressure in the lungs to be less than atmospheric pressure. So in order for air to move in the lungs, in order for inhalation to take place, what we want to do is increase the volume of the lungs. We encourage that by having the muscles of respiration allow for chest expansion. So for example, we have the diaphragm that will move down and increase that diameter of the chest. And then we have the intercostals, the muscles between the ribs that help also with the expansion of the chest and increasing the different diameters of the chest so that we can increase the volume. And by increasing the volume in the lungs, we decrease the pressure in the lungs. So if the pressure in the lungs is less than the pressure in the atmosphere, air will move into the lungs. Okay, so to move air out of the lungs, the elastic recoil of the muscles of the diaphragm, the intercostals, will go back to place, go back into their regular places in order to decrease the volume of the lungs. So we decrease the volume of the lungs. This increases the pressure in the lungs. So at this point, the pressure will be greater than the atmospheric pressure. Air will then move out of the lungs. Now, usually the pressure difference between the atmosphere and the lungs is only about 3 to 4 millimeters mercury, but it's this pressure difference between the lungs and the atmosphere that allows for movement of air into and out of the lungs. Okay, so just remember that pressure is inversely proportional to volume. So again, as we have an increase in volume in the lungs, we have a decrease of pressure in the lungs, allowing for movement from the atmosphere into lungs because the pressure in the lungs is less than the atmosphere, and vice versa. So here we're just showing a highlighted area of the Biopac recording. We can see on the bottom of the recording, chest movement going down, so this is exhalation. So as we exhale, we are decreasing the volume in the lungs. As the volume decreases, we have an increase in pressure. This allows for air to move out of the lungs. And as air is moving out of the lungs, we can see that the temperature change, we have an increase in temperature, okay? Because basically we are exhaling out air out of the lungs that has had time to kind of sit in the chest and warm up. So the air leaving the body is a lot warmer compared to the room temperature that the volunteer is breathing in. So with regards to the order of the events, first we're going to have a change in volume. Okay, so in this case, volume will go down. This will then lead to the movement of gases. So when volume goes down, the air moves out of the lungs. This will then lead to the change of temperature, or the delta T in this upper part of the recording. So we have change in volume first, that lead to the movement of gases, and then the change in temperature that we see in this recording. So again, an increase in pressure allows for movement of air out of the lungs, and then the temperature goes up because the air in the lungs has been warmed in the body, and is a lot warmer compared to the ambient or room temperature. Okay? So again, with regards to the events that occur, we'll have a change in volume first, and then we'll have movement of air due to the change in pressure. So ventilation is basically negative pressure breathing. We decrease the pressure in the lungs so that before we do that, so in order to decrease the pressure in lungs, we have to increase the volume. So increasing the volume first allows for chest expansion, and then we create a negative pressure, so the pressure will be less than the atmospheric pressure, allowing for the air to flow within the lungs. Now, since airflow lags behind chest movement, the temperature change will lag behind chest movement as well. Okay, so again, the order of events, we have a change of volume first, then the air moves, then we have temperature change. So this is ventilation. This is what we are looking at in these recordings. So then we have the three conditions that we are testing within the lab, with this part of the lab. So we have normal eupnea, or normal resting breathing occurring in this blue part. Then we have hyperventilation, which are rapid, deep breaths. We can see that the respiratory waves are a lot closer together with hyperventilation. So because we're doing more rapid, shallow breaths, actually. So rapid, shallow breaths, this allows for the respiratory waves to be closer together. There will be the change in temperature is smaller because the air does not stay in the lungs very long, so the change in temperature is smaller and the air is cooler. With hypoventilation, this should say slow, deep breaths, the respiratory waves we see are a lot farther apart. The change in temperature is smaller, and the air is warmer because the air stays in lungs and body longer to warm the air. So chest movement is less, temperature change is more, it takes longer time in the lungs to warm up. So those are the three conditions that we are measuring in lab. There's another lab where you can show a part where you're reading out loud. If you ever take the time to look at the Biopac tracings for that, they're pretty erratic, and it's kind of hard to, determine chest movement and breathing as well as air temperature when a volunteer is reading out loud. But don't be surprised if you kind of, see other experiments where they talk about, being hooked up to the Biopac and having to read out loud. But for the most part, you should have an idea of what happens during these three conditions, during eupnea, hyperventilation, and hypoventilation. What happens to chest movements? What happens to the change in temperature or airflow? Also be aware of Boyle's law and how and the events that's starting with the volume and then the pressure, or the volume and then the movement of gases, and then the change in temperature. So make sure you're aware of those events and make sure you are comfortable with doing Boyle's law and how it applies to inspiration as well as expiration. Okay, so that's that explanation, introduction and explanation of the first part of the lab. The next discussion we'll talk about the respiratory tracings, which is a little bit complicated. But yeah, we'll have another lab video regarding